Hello everyone. Now I'll be discussing question of cardiology. So we have a 42-year-old man who come to emergency with episode of syncope, and as far as medical history is concerned, he's he had a upper respiratory tract infection 1 week ago. On examination, temperature is just slightly raised, pulse normal, BP 90 by 60, respiratory rate is 13 per minute, neck veins are distended and heart sound are very distant. His lungs are clear on auscultation bilaterally, and chest X-ray reveals small bilateral pleural effusion and an enlarged cardiac shadow. Well, most likely EKG finding that we expect in this will be. Well, the answer to this question is electrical alternance. Why this? Why not others? So this patient has pericardial effusion. Okay, and we all know very well the pericardial effusion lead to electrical alternance. In ECG or EKG. Now, what's the clue that we are dealing with cardiac or pericardial effusion? Recent upper respiratory tract infection is a clue to our diagnosis, because most of the time pericardial effusion are often secondary to viral pericarditis. Okay. Now look into the ECG. When we talk about electrical alternance, as it has been asked in the question, the QRS complex amplitude varies beat to beat. Look, this is like height varies. This is the classical that we get in electrical alternance. Okay. So beat to beat variation of the amplitude of the QRS complex is there. Well, but why this happened? What's the basic idea behind? As the heart is hanging in a bag full of water, it swings back and forth with increasing quantity of pericardial fluid. That's why it is moving, and that gives a varying height of QRS complex. Now, what are the features which are really suggestive of in this patient? The patient has got pericardial effusion. JVP is distended, muffled heart sound, borderline BP is just 90 by 60. Okay, in fact, these three are also known as Bake's triads. Of pericardial effusion or cardiac tamponade. Enlarged cardiac shadow, which is there in X-ray also. So what actually we get it? We get a so-called money bag appearance, and that is very nicely depicted in this picture. Also, money bag appearance. Cannot afford to forget this picture. Now, when we do echocardiography to confirm it, look into this. You like this. You are getting this echo-free area. Very nicely seen in this picture, echo-free area. Here also you can see. Now, what is Ewart sign that we classically see in cardiac tamponade? Stop the video, write down the answer. Well, Ewart sign is that this is the trachea and two bronchus. Now, in massive cardiac tamponade, the heart enlarges, and that compresses. The enlarged heart will compress this bronchus, left bronchus. So now there will be some narrowing of the left bronchus because of pressure on this, and that lead to narrowing, and that we can hear a bronchial breathing. In the left angle of scapula, and this is known as Ewart sign. Well, other option, prolonged PR interval, that is indicate first degree heart block. first degree heart block. We know very well normal PR interval is 0.12 to 0.20 second, and a prolonged PR interval that is more than 0.20 second is first degree heart block. Like in this case, look at this P wave, and you are getting a PR interval of around 0.28 second. This is the first degree heart block. This is not seen in cardiac tamponade. F wave, with this we see diagnostic of atrial flutter. Look, the classical finding, okay, and JVP, distension and hypotension can develop if heart rate is very rapid enough, but here the heart rate is only 90. That rules out atrial flutter, because in atrial flutter ventricle rate is very, very high. But just to inform you, you can see this sawtooth appearance. Sawtooth appearance. And in this, classically, there is so. Now, when we are seeing the picture, additional knowledge for you, rise is slow, but descent is very fast. That's why you get picture like this, sawtooth appearance. Delta wave, this is classically seen in WPW syndrome. There is a notch in the ascending limb of R wave, and the PR interval is short. PR interval is usually less than 0.12 second, and you get a delta wave. They are the two classical findings that you get in ECG of WPW syndrome. That is not a feature of cardiac tamponade. New onset right bundle branch block can be seen in acute pulmonary embolism. This is not a finding in case of cardiac tamponade. And this you can see lovely picture. You can see this is R-R pattern in V1, and you are getting almost a M pattern, and you are getting classical finding broad S wave in V6, and we are getting it tall R wave, second so-called R wave, S wave in V6. This is typical of pulmonary right bundle branch block. Now again, I got some more question for you. Stop the video, write down the answer. What are the most common finding in ECG in pulmonary acute pulmonary embolism? Paradoxical bradycardia can be seen in which condition? Okay, well, the right answer is tachycardia is the most common finding in ECG. Paradoxical bradycardia is seen in pulmonary embolism. Point to be noted, the most common finding is tachycardia, but at the same time, sometimes bradycardia can occur in pulmonary embolism, what we call as pulmonary embolism, or so-called paradoxical bradycardia. And finally, the most characteristic finding is S1, Q3, T3, you get S wave in L1, you get Q wave in L3, and T inversion in L3. This is the most characteristic finding is so-called S1, Q3, T3 sign. Well, golden line to remember, electrical alternance is when the amplitude of QRS complex vary from beat to beat. It is fairly specific for pericardial effusion. Enlargement of cardiac shadow can be seen on pericardial effusion. This we can see in chest X-ray. Okay, and classically what we got is money bag appearance, which I have shown you the picture also. And in the echocardiography, we can really confirm, and what we got is echo free area. Thank you very much.